amyloidosis.
Great. So thanks everyone for having me. I want to especially thank Alyssa and her dad, John, for inviting me. I think programs like this are really essential to highlight some of the progress we've made in medicine, and also to make sure that we continue to make progress. So I'm going to give you guys a pretty brief, hopefully 15-20 minute overview. Hopefully you can see my slides. This is actually a presentation, Deborah, that I gave to many of the patients at the support group a long time ago. And this condition we call wild type transthyretin cardiac amyloid, or ATTRwt, as shown here. And I like to describe to patients that this right here is the little bugger that causes the problem. This is a picture of the protein transthyretin. It's a protein, as you can see in the colors, made up of 4 identical subunits. Red, yellow, green, and blue are all the same protein. They each have like a little alpha helix corkscrew here, and they each have many folds, which we'll talk about in a minute. Those are called beta pleated sheets. And it fits together pretty nicely into this nice structure and function, which is very important for it to do its job. It was actually discovered at Columbia University in the 1970s in a guy named DeWitt Goodman's lab, for those of you history-wise. In 1970, no one could sequence proteins. No one could make nice pictures like this. All they could do was separate proteins in size order, like a kindergarten picture, tallest to shortest. And so this protein showed up in size before albumin. So if you ever measure it in the bloodstream, you're going to order a pre-albumin level. That's the blood test that's ordered. And over time, we figured out what it does. So we renamed it transthyretin, because the trans, first T, is because it transports stuff. What does it transport? The thi stands for thyroid hormone. It's one of the minor carriers, or many carriers, of thyroid hormone in everyone's body. And retin stands for retinol, which is vitamin A, and it's the only carrier of your vitamin A. So if you don't have this protein, you can't transport vitamin A to your tissues, and God forbid, if you had that problem for a long time, you could have vision trouble, because vitamin A is essential for night vision, for example. And notably, one of the guys who studied this protein the most, a guy who invented a drug called tafamidis, is named Jeff Kelly. If you ask him, well, why did you pick this protein to study as a chemist? He said, because it was heavily beta pleated sheet structure. And proteins that have this back and forth beta pleated sheet are often proteins that can link together, as I'll show you in a few cartoons, and form amyloid. So proteins like this are much more amyloidogenic. How do you get this condition? Well, this is the tetramer that I talked about, the 4-leaf protein that's produced that links together, and either with normal aging or with a genetic variant, which people with wild type don't have, because it's what exists in the wild, the protein becomes unstable and falls apart. And so here's a piece of the protein, like the blue piece, and the blue pieces and other pieces can line up into these amyloid fibrils. And if they get stuck in your heart, we call that transthyretin amyloid cardiomyopathy. And the protein also seems to like the nerves. So sometimes we call that transthyretin amyloid polyneuropathy. And many patients may have kind of a mixture of these kind of manifestations clinically. And these individuals usually have a genetic cause, and they present earlier in life, and patients with the age-related wild type cause usually are over the age of 60 years. There are other names for this condition. I don't make up any of these names, but these are the old names you may read in the literature. People used to call it senile cardiac amyloid, not because anyone's cognitively impaired. Senile just means an older adult, but that's how doctors describe things. They also called it SCA, or senile cardiac amyloid. It's actually probably not so only localized to the heart, though the main organ it goes to is the heart. And so people have called it senile systemic amyloid, because there could be deposits. There should be deposits in other organs. Some people call it age-related cardiac amyloid. This is kind of an interesting graph. This is the age of people. So, 10, 20, 30, all the way up to 90 years of age. And this is what we call cumulative incidence curve. And so each one of these dots represents a patient, for example, that we saw years ago. So this mutation is actually common in people of Danish descent. It's only been described in people who are Danish, in which this methionine, which is amino acid, replaces leucine, because there's a genetic switch at the 111th position. And you can see this shows up in people who, one person was 36, and this person was maybe 37, and this person was 40. So if you went along here at the 5th 50th percentile, you'd say, well, this shows up on average age of someone who's about 40, 45. And this shows up, this mutation here is called the Irish mutation. It affects people of Northern Irish descent in Donegal, and those patients on average, it's a wide spectrum, but on average are kind of in their 60s. This mutation is the most common seen in the United States. It's called isoleucine to valine at the 122nd position. Almost exclusively affects people who are African-American or Black. 4% actually of African-Americans carry this mutation. It shows up on average age of about 70. And then you can see the wild type average age is about 75, though there are people who, John will describe his story, who can manifest it earlier in life. So interesting, and we don't know why it shows up later in life. It's kind of biologically, no one's figured that out. Just a brief word about, you guys know this from chemistry, but just to remind you in production of proteins, this is just a cartoon to remind you that, here's the nucleus in the cell, here's your DNA, and your DNA is unraveling, and your DNA gets coded, right, by messenger RNA, and here's the message being formed, and the message is complementary to the DNA strands, and then it gets transported outside the cell into the cytoplasm, where there are ribosomes, and the ribosomes use transfer RNA to basically make the protein. And you can see here's 3 amino acids making three segments of DNA, letters making each of the proteins. And here you are, manufacturing a protein. And this goes on in your body all the time. And over time, you have a very, very, long time passes. You made the primary structure of the protein here. And eventually there's a kind of a stop code on it, says I finished manufacturing that protein. But that's not the end of proteins. And I have to give a shout out, I think, to Mother Nature. I don't know if you really appreciate this, but proteins are the most abundant molecules besides water in the world, right? And each protein is made from, this amino acid structure. So this protein, transthyretin, has only 127 amino acids. We know the normal structure of it, the picture I showed you before. But that structure leads to the protein to fold into a exact shape and structure. And believe it or not, a simple protein like transthyretin can go into billions or trillions of different shapes. So the fact that the protein folds in the right way and gets into the right shape and doesn't go awry all the time is kind of a real testament to human biology, that it works that well. So you can hear this, but I'm just going to speak above it. Here's the primary structure of the protein, of the amino acids. And then the protein will fold and form what we call a secondary structure, you'll see in a minute, in which you might get, beta pleated sheets or alpha helixes. And then it's going to get even a tertiary structure. It's going to fold on itself, so this is so that's the beta pleated sheet structure and the alpha helix, but then it could twist and fold on itself to get into the right shape. That's called the tertiary structure of a protein. And all this happens in your body kind of all the time. And then there's even a quaternary structure, which in transthyretin is important because the 4 proteins have to fit together, the 4 identical proteins. So imagine your body's kind of making proteins all the time and trying to do a good job. And here's what happens when the proteins don't fold right. So here's just a cartoon. Here's a protein that's trying to find its right shape and structure, but for some reason it's not able to, biologically. It can't figure itself out, and it leaves like this little part, maybe right here, hanging out, which should have been folded inside in some regard. And this little part here can line up with other proteins. This is the beta pleated sheet structure, and they can rapidly assemble. And you'll see they all kind of line up along that line and form the amyloid fibrils. And amyloid is really a protein deposit. It's very hard to degrade. It's resistant to what we call proteolysis or protein degradation. And so that's what amyloid is. It's a protein misfolding disorder. We don't know why, but this protein, as I said, likes the heart. I don't know why. It interestingly also likes, it looks like ligaments. So many patients with this condition will have a history of carpal tunnel syndrome, in which they'll describe some numbness in their hands or their fingers, particularly worse at night. They may have had previous carpal tunnel surgery, important historical thing. We've learned many patients have spinal stenosis. This is your spinal, cord. These are the bones, and here's your spinal cord here. And you can get a compression of the spinal cord, which we call lumbar spinal stenosis, and that's pretty common in people with this condition too. And why do certain patients develop certain manifestations? We don't completely understand, but these clues are really important because lots of people have cardiac conditions. You want to be attuned to whether or not someone historically might have the orthopedic manifestations or some of the neuropathic or neuropathy manifestations. This is an example of something that's really interesting, was described by a colleague of mine, Rodney Falk, who's up at the Brigham Hospital in Boston. This is a great sign. If you can find it, you'll look like the star medical student in your class. All you have to do is take off the patient's shirt, ask them to bend their arm up, and the biceps tendon here bunches up. And that's what's called a Popeye sign. You look like you're Popeye the Sailor Man, if you've ever seen the cartoon. That rupture of a biceps tendon, if someone has a thick-walled heart, is basically equal to transthyretin and amyloid. You don't need to do, you will do other testing to confirm it, but you can tell your attending, you know, I know what this person has. They have a thick-walled heart, they have a cardiomyopathy, and this finding, especially in someone who's a male over 60, that's amyloidosis, kind of. And it somehow results in the amyloid depositing in the biceps tendon and resulting in its rupture. So how does this affect the heart? These are little cartoons here, or echocardiograms. This is a normal heart, I think you can see. This is what we call a cross section. This is the heart kind of taken and sliced like a piece of bologna. And we're just doing an echo here. We can see the heart is squeezing pretty well. It's contracting very nicely. Here's the heart in what we call four chambers. So you can see the different chambers. This is the left ventricle. This is the mitral valve opening and closing there. And this is the left atrium. So blood goes from the left atrium to the left ventricle, then gets pumped out another valve, the aortic valve, to the body. This is the right atrium, and this is the right ventricle over here, and this is the tricuspid valve. So you can get a nice sense of the heart. Each one of these little yellow dots here is about a width of a centimeter. So I think you can appreciate this heart is not very thick, right? It's about a centimeter thick. It obviously thickens when it contracts. Here, look at the patient with amyloid, right? I mean, you can get, this heart is much thicker. The chamber is much smaller. The cavity of the heart is much tinier. It doesn't look like it contracts as well. And here, in what we call apical four-chamber, you can see the atrium here is way bigger than the normal atrium. It's trying to push the blood into this heart, but this heart is very thick and leathery, and it can't dilate. So imagine you're trying to push blood into like a balloon made of leather. The atrium gets big, and the chamber gets smaller. And this is a very, very thick-walled heart. And the reason the heart's thickening here is because the protein is getting stuck inside the heart, or depositing. As I implied, there is a form of this condition which we call ATTRwt, or really now we call it variant. We don't like the word mutation because it sounds like, you know, it's not PC, or wild type. ATTR variant is affects people of various ages depending upon the mutation or variant in the protein. There are literally over 130 variants or changes in this small little protein that's only 127 amino acids. And the gender distribution here is pretty equal. Who's affected, as I said, depends upon the variant. People of Irish descent often have a certain variant. People who are African American have another. And this tends to equally affect the heart and the nerves, sometimes the eyes. Whereas wild type transthyretin in the non-genetic form seems to affect men much more often than women so far, predominantly at least Caucasians, though I'm not sure that's really true completely. I'm sure other ethnic groups get it because we all get old, and it almost exclusively affects the heart. As I said, this is a normal heart, just to teach you a little bit about this measurement that every cardiologist is in love with. It's called the ejection fraction. And I note here why the EF, or ejection fraction, literally sucks for making this diagnosis. So every patient with amyloid could have a normal EF. They could feel really terrible, and the doctor's like, oh, you don't have a heart problem. So it's important for you to understand this is the normal heart muscle. As I said, it's about 10 millimeters or 1 centimeter thick all around. And the normal heart contracts and it squeezes, it gets smaller, and it, you know, pushes the blood out. And the heart holds, on average, when it starts, about 100 milliliters of blood. And when it's done pumping, it holds about 30 milliliters of blood. So I don't think you need to be a rocket scientist to know that 100 minus 30 is 70 milliliters. And so if you divide the 70, what it pumps every beat, by what it holds, you get an ejection fraction, which normally is above 50% or 70%. So here's the problem in amyloid. The heart's much thicker. It's 2 centimeters or 20 millimeters thick. It contracts and it gets really small. So it may start with only 50 milliliters of blood. Why only 50? Because you can't expand this leathery balloon. It can't hold as much blood, but it goes down to 15 milliliters, right? So 50 minus 15 is 35, and 35 divided by 50 is still 70%. So often the patient goes to the cardiologist and says, I can't breathe, I'm short of breath. And the cardiologist, I hate to say it, is a little not so bright. And he goes, well, your heart's pumping fine. There's no problem. But for a pump to work, it's not only got to pump, it's got to fill. You can buy the world's strongest pump in the world, but if it holds the amount of water in the tip of my finger, it ain't going to pump very much water to the top of the building to flush even a half a toilet. So this is the problem with amyloid. The heart becomes not capacious, too small and thickened. And we see patients for years being told, this is not a heart problem, or they don't know what this is, or it's some other genetic condition, hypertrophic cardiomyopathy or something else. One thing that's revolutionized the field is the way that you had to used to make a diagnosis. I'm pretty sure you'll tell us, John, if this is how your diagnosis was made. But you used to have to do what's called a heart biopsy, which when you tell most people that, they often think you're talking about Pulp Fiction and you're going to stick a needle through their chest, which is not what we do. We put this catheter into the vein into their heart, and it's called a bioptome. And literally the one handle of this catheter, you don't see it outside the chest, but it has a scissor handle. And the other is just like this. It's a little jaw, and we push it up against the heart and we grab a piece of the muscle and we can pull it out and look at it under the microscope, and we can see the amyloid or the protein deposit. And that's not something that most people want to do, and they have to get it done in a specialized center, and there has to be an expert pathologist to read it. And so all of this has led to a lot of the delays in the diagnosis. What's kind of revolutionized the field is we can now make this diagnosis with a scan. I don't expect you to know exactly about it, but this is a scan using an isotope that we call PYP, or pyrophosphate. It's been around for 50 years, and it's been used in nuclear medicine to image the bones. And here's a patient who's normal, in which we inject the pyrophosphate and it images their sternum. This is your sternal plate here, and there's no uptake you can see anywhere near where the heart is. And I don't think you have to be a heart doctor to see here in this patient, there's uptake right where the heart is in the left chest, and there's none on the other side. And we can use this to make the diagnosis non-invasively in many patients. So how do we treat patients with this problem? In the past, everything was just kind of treating the symptoms, like here. So we would make sure that they asked them to eat really low salt diet, because if you ate too much salt and you became full of water, you'd be swollen and short of breath. And we often have to use certain diuretics if the patient's not very adherent to a low salt diet. Many patients develop an abnormal heart rhythm called atrial fibrillation. About a third of patients that we see when we first meet them have AFib. About half of patients in a big study that we published in the New England Journal had it. And over time, almost everybody in our experience, 10 years develops it. And so many of these patients need to be on a blood thinner to prevent a blood clot that forms inside the heart from, God forbid, traveling anywhere. There's a drug called a calcium channel blocker that we often don't want to give these patients, because it turns out, just to go back, that this isotope binds to calcium in the heart. And if you give people a calcium channel blocker, it binds to the amyloid fibrils, and it can cause problems. It can cause a very slow heart rate or low blood pressure. So cardiologists need to know that someone has amyloid and avoid, or any internist needs to know to avoid using certain calcium channel blockers in such patients. And then over time, some people can get a very slow pulse and, God forbid, not a big deal, but sometimes need a pacemaker. We didn't have any particular treatments for this problem, but a series of investigations over about a decade resulted in some treatments that have now been approved. One treatment is a drug called tafamidis, which is basically what we call a transthyretin stabilizer. It's a pill you take once a day. It goes in between the leaves of the protein, where I showed you the protein tends to fall apart, and it locks the protein together. It stabilizes the protein, preventing it from dissociating into pieces. And so you ideally stop or slow down the development of amyloid, because there's no more pieces floating around. There's also another drug that was discovered by Dr. Kelly, who invented tafamidis, that's a non-steroidal, an anti-inflammatory that looks a lot like chemically tafamidis. In fact, he discovered that this would work in some patients, but because it had a lot of side effects, non-steroidals can cause an upset stomach and gastrointestinal bleed, and it can cause kidney dysfunction, fluid retention. Dr. Kelly, who invented this, decided he was going to make a new compound, and that's how he came up with tafamidis. And for patients, John, like yourself, these were really the only two options that are available. But you'll tell them your story about how you enrolled in a clinical research study. Because tafamidis works, we've now learned that there's a wealth of experiments and studies that are being done in this field. And these are what we call the names of studies that are currently being performed in what we call phase 3 clinical trials. So we do phase 1, we try to see if a drug is always safe, but we're trying to figure out what's the right dose. Phase 2 is more safety data, but phase 3 is, wow, we got really far along, we're confident, and now we're going to see if this drug actually works, right? If it works, then we're going to give it to patients. They're going to be able to get FDA approval and put it on the market. So in a very short time, we have now 4 phase 3 clinical trials that are using drugs that either can stabilize the protein like tafamidis. You'll tell more, John, you're on this particular medicine called AG10. But there are other drugs that literally can go to your liver where the protein is made and tell it to stop making the protein and silence the protein. And so the theory is if you don't make the protein anymore, you won't have any protein that's bad hanging around, you will stop the disease. Obviously, if you stop making the protein, you need to take a vitamin. Which vitamin? You have to take vitamin A every day. Otherwise, you become deficient in vitamin A because there wouldn't be enough to carry around. So that's just a high-level summary of the disease. And I will stop there. I look forward to questions later, but I'll turn it over.
Thank you. Very detailed and a great explanation of the disease. And I appreciate it because the first time I met Dr. Maurer, a little bit more general presentation I got from it, but just going in for the first time and talking to a doctor about the disease and hearing the explanation, for me, it kind of takes the mystery out of the whole thing. And you kind of want to know what's going on when you see a doctor. Otherwise, why bother go to find out? In terms of diagnosis, mine, I can't even tell you how far back it started. I had a doctor called Dr. Seberg, who was a sports medicine doctor here in Hawaii. It started with him back in the late 90s, early 2000s, when I had joint replacements. And he said, you're too young for this. There's something else going in your body. I don't know what it is, but we got to find it. They worked me up for lupus. They worked me up for so many diseases. I went to a rheumatologist and they still couldn't find anything that would define the problem. The other thing he noticed or identified was the ligaments rupturing. You talk about a Popeye arm. Well, that's what it looks like on me.
Wow.
That was my right bicep.
Wow. That's, I mean, I hate to say it, but I wish I would have just asked you to show it to begin with. Can you just do one more time for everybody? Just because I think it's, yeah.
So it's an abnormal bulge. And that happens when it ruptures from the proximal side versus the distal side. That wasn't enough, though. Before that, I had dual carpal tunnel surgery back in 2007. And if anybody's had carpal tunnel, you know how painful it is. You wake up in the middle of the night like your hands are on fire. Someone put a torch to it, pour gasoline on it, and then put a torch to it, and you wake up with that. And eventually it will cause nerve damage and you'll lose the feeling in your hand. So I went to an orthopedic surgeon. He said, all right, you need carpal tunnel release. And I did it. The thing that I wound up with was I wound up doing it within 7 months on both wrists. The frustrating part is that's a huge red flag. If you look at the Popeye arm, you hear the carpal tunnel syndrome and you go, why didn't anybody think about it? Well, they don't think about it because it's not, orthopedic surgeons don't really think about that part. I've had a lot of experience with them and they're body mechanics and I get it. But that's why they're doing what they're doing. And there's the fact that this disease couples itself to other disciplines. I think the more they're aware of that, they could probably possibly head off a severe problem that's coming down the road. I didn't have that luxury. In 2014, going from 07 to 14, well, 2 years prior to that, I was having my final joint replacements. I've had 4, 2 knees and 2 hips. I also have spinal stenosis. So when they did the final surgery, I noticed a lot of arrhythmias. I could feel my heart doing crazy things. I could feel the pulse being rapid and slowing down, just doing a lot of abnormal things for me. So I went to my cardiologist and said, hey, before I do this last surgery, I don't want to wind up on a gurney getting rolled out of the OR. I want to know what's going on with my heart. So they did a test. Because you have joint replacements, you can't really put me on a treadmill and have me run for 10 minutes because you can't run. So they got to get my heart rate up, and they did that via a thallium study. Basically, they lay you down in a bed in a recovery area. They inject you with something that's going to elevate your heart rate slowly and get you to about 140 beats per minute to see if there's any abnormal rhythms that are coming up. Mine didn't really show much. They said, the cardiologist came in and said, I wish all my patients looked like this. So they cleared me for surgery. The one thing they did as part of the test as well, though, was an ultrasound. And as it turns out, going back in history on that ultrasound from 2014, when I'm trying to get a diagnosis, and going back to 2012, the heart wall was already thickened in the ultrasound. Who do you blame that for? Well, you don't blame anybody, but you have to figure that diagnostic process started somewhere else, and it didn't start with the cardiologist. So a radiologist, whoever reads those, at some point, it might have triggered it to know that, hey, this guy had carpal tunnel. We're doing an ultrasound. It looks like his heart wall is thickening. We need to, we need to move forward on the heart and not worry about everything else. That didn't happen. 2014, I was fortunate enough to have an event of syncope, where basically I just collapsed. There was a lot of reasons for it. I traveled 12 hours, 6,000 miles. And I had gone out with my friends, had dinner and a few drinks, showered, and all of a sudden I dropped on the floor. Went to the emergency room. The EMTs came and did my blood pressure. It was 90/60. They took me to the hospital, to the ER, where they worked me up for a heart attack. Well, nothing showed in that, and my EKG looked normal. So again, there was no diagnosis, and this is 2014. My daughter was going to Florida to go to school, and we were taking her down there in 2 days, and a family member said, hey, look, I know the ER checked you out and you did well. Why don't you go see this cardiologist before you go down there? So I made an appointment. He said, yeah, come on in, we'll squeeze you in. Only half the staff was there, so they couldn't do all the tests. But what'd they do? He did an ultrasound on me. And the cardiologist comes in and says, that's interesting. I kind of cleared my throat and said, that's not a good word. And he goes, you got that right. So he said, listen, your heart wall is thickened. It should be about 11 millimeters. It's actually about 15 and 16 in some areas. He goes, you need to figure out what's going on. And when are you going back to Hawaii? I said, probably 8 days. He says, go see a cardiologist and get a workup. So I returned with, if you have an event of syncope, you're out before you hit the ground, which is an unusual feeling. And you kind of, that feeling and that whole process stays with you. So you're kind of like, you're almost afraid of walking. I'm looking at steps and how steep they are and where the railings are, because I figured I got to break my fall if this happens again. I didn't, fortunately, and it hasn't since. But when I returned to Hawaii, they started with the treadmill, the ultrasound, and then the odd part was, before I even started that, a nurse practitioner walked into the room when I was for my first visit with the cardiologist and gave me a handout or a printout of about 50 pages thick. And it was on amyloidosis. I don't know how she knew, but that's pretty much who tipped her hat first. And I looked at it, and the first thing I looked at is, what is this? And the next thing I looked at is life expectancy. It's all on the first page. And I said 3 to 5 years. So that really got my attention. And I said, why are you giving me this? She says, you might want to read up about it. And I said, fine. My cardiologist said, don't read anything, because you don't want to go down any rabbit holes until we're done. So needless to say, I went on the internet and read some more on it. ultimately, the heart wall thickening was there. When they did an angiogram on me as well to make sure that the vessels were clear, and they were. And that's when I started asking about the work that was done, or the diagnostic work that was done in 2012, because I wanted to start establishing a timeline if I had amyloid. And that timeline to me meant 3 to 5 years. So when did this actually start? Well, it was in 2012 that they found the heart wall thickening as well. So again, there were some indicators in 07, in 2012, and now in 2014. Where I was at was this. They did a cardiac MRI. That was interesting. You're holding your breath for an hour and a half in this tunnel, and you're holding it for 30 seconds at a time. Of course, you're breathing, yes, but can you hold your breath? How long? 30 seconds. Okay, get a good breath and wait. What they found in that was there was amyloid deposits, but they couldn't determine which one I had, and there were 3 varieties. So my cardiologist said, look, you got one of the 3. I doubt you have one of them. You wouldn't be around right now. It's probably one of the other 2. I said, okay, how do we figure that one out? He goes, well, we need a biopsy of your heart. Hence I said, well, that's kind of, how many of these do you do here? And this is in Honolulu where I live. He says, well, we used to do a few of them, but we don't do them anymore. I mean, it's rare. So I'm thinking about all the tests I've gone through, and the things being missed or misdiagnosed or whatever. I don't find any fault in that. I think it's a matter of just looking for it versus not being aware of it. And so I said, okay, time to get on the phone. I called New York and called the cardiologist that I originally talked to, and I said, this is what they think I have. What do I do? Because they want to do a cardiac biopsy. And that's where I had the fortune of meeting Dr. Maurer. His words to me were, go see this man. He gave me his name. He's a Columbia Presbyterian. Call him up. If you have any problems, I'll call him. And he goes, he'll see you. It didn't take that much. I called. I talked to Dr. Maurer for about 10 minutes. And I went through some of my symptoms. First question he asked me was, have you had carpal tunnel? I said, yeah, dual carpal tunnel. Yeah, close together? I said, yeah, within 7 months. He says, okay. The next question was, when can you get here? My feeling was, when do I need to be there? And he said, well, I wouldn't wait too long. I said, all right, 30 days to get a plane ticket, because now I'm traveling, 5,800 miles for a doctor's appointment. I'm thinking, okay, I got to get, a reservation. I got to get a plane ticket that's reasonable, et cetera. He said, well, 30 to 45 days is fine, but I wouldn't want to see you wait too much longer. So I made the appointment, got to New York. There was a huge snowstorm a couple of days before the appointment. Everything was closed. All the major trains were closed, highways, freeways, everything was closed into Manhattan. So we had a good conversation on the phone the night before my appointment, and got it rescheduled for 2 or 3 days later. Again, Dr. Maurer was very open. It didn't really matter when I got there. He said, I'm going to be here. You get in when you can, and we'll be here for you. Just give me the time. And I wound up, I think, on a Thursday or something like that. I don't really remember the day, but it's, 7 a.m. I was there at 6:45. So was Dr. Maurer. And, he unlocked the office, and we went into an office. I had 2 people with me because I didn't trust my hearing and what I'm going to hear. So I wanted other people around to listen to it and compare notes later. And we did that. And to me, that's very useful for a patient that's going through something this profound. You're only going to hear so much, and you're going to mishear some of it. And believe me, that happened. But Dr. Maurer sat down for 2 hours and went through the disease, kind of like this slide presentation, but more on a higher altitude view, but in more detail down the road. Of course, I asked him the big question, how long do patients survive with this? He says, well, it's 3 to 5 years. He goes, but I'm suspecting we're catching it fairly early with you. So who knows, maybe 10 years. I said, okay. Sounded better than 3 to 5 to me, and that's what I hung my hat on. After that, I did do a cardiac biopsy when I was there. I'll just make a comment about that. What I recall was there's no pre-meds before you go into the procedure. And I think that's mainly because they want the heart functioning as normal. There was a numbness put in my neck to send put the catheter down through it. And the first biopsy they took, you're laying in a cath lab and there's maybe 7 monitors that are huge. You know, you should be watching CNN or some sports show on it. And you're looking at your EKG waveform up there, and you're noticing as this scissor looking thing is right in front of your face, or your head's turned towards it, is slowly moving deeper into your neck or whatever. But you see the scissors there no matter what. And the next thing you feel is you're going to pass out. You're looking at your waveform disappear. You're looking at starting to flatline. You're going, that's me up there. A cardiologist is priceless. He goes, how you feeling, Mr. Basdavanos? I said, like I'm kind of going. She goes, oh yeah, it's your heart. It's kind of angry with us. A little humor, I thought, and it was needed at that moment, and it felt good. But the other thing you see is the defibrillator 5 feet from your face that's sitting there. These are all preventative things, but it's kind of a little memorable to go through that. When I finally had my 6th biopsy, I wanted to know if I was counting correctly, because she said, we're doing 6. I said, good. I thought I was counting 6 times that I went through this. I said, are we on the last one? She goes, yeah, we are. I said, thank God. And that was the end of it. But that verified what I had. I did go through the other tests with the nuclear medicine, because I think they were trying to actually get that approved versus taking biopsies. So I kind of went through both. And of course, they both came out positive for amyloid, and it was cardiac involvement. I guess after that, the first thing I went on was deflusanol or Debolid, which is an anti-inflammatory. I found that ironic because I've been on anti-inflammatories because of joint replacements, and prior to joint replacements, you're taking a lot of NSAIDs and everything else. So I'm going, well, here I am. I thought I got rid of these things, and now I'm going back on them for my heart. Just didn't add up right for me, but that's the way it went. Fast forward, they did a lot of other workups on me because I think they wanted to track the progression using different tests, and I think I was a good study object for that. So I kind of volunteered. About a year after that, I was contacted by Dr. Maurer's research people asking me if I wanted to go on a clinical trial. And I didn't really have to think about it and hesitate. I said, yeah. You know, you have to like make a decision early. You know, I think, do I want to fight this thing and any way possible and take a risk? Yeah, because the risk was minimal to me compared to what you're looking at down the road. So I started that trial, I believe, April of 2018. I went back to Columbia. Now, keep in mind, all my tests, everything was going back to Columbia. When I started this clinical trial, I had to get a workup to see if I was a candidate. Fingers were crossed. I was a candidate. That was a relief because that could go wrong. The next thing was I had to go back every 3 weeks for blood work. So if you think about commuting from Hawaii to New York every 3 weeks, you get to New York, take you 2 or 3 days to recover. You'd have your appointment. Then you fly back to Hawaii, take you 2 or 3 days to recover. Next thing you know, you're flying back to New York again. It wasn't, to me, at the end of the day, that wasn't too much to ask. The inconvenience compared to what the potential was far outweighed by the potential. So I felt good about it either way. I started on AG10. The original trial went for 60 days. 1/3 got a placebo, 1/3 got full dose, and 1/3 got a double dose. I think after that, they got approval to do an IRB from the FDA, and everybody who had gone through that trial was going to go on the drug. So I think by mid-August or late August of 2018, I was on AG10, and I'm still taking it now. The dose is 1,600 milligrams a day, which was double dose from what they started with, and it's been effective. That's the least I can say about it. Hypertrophic cardiomyopathy, congestive heart failure. I guess technically that's what I have. I've been fortunate enough at this point not to be symptomatic from it. Swelling, I've been able to keep down with a low salt diet. And That's pretty much it. I think I'm doing well right now. I do certain hikes here in Hawaii that are about 3.5 miles. Part of it's stressful, the other part's non-stressful because it's uphill and then downhill. So I time myself at certain points to see where I'm at. I've been doing that for 4 years prior to being on anything, and I've remained pretty consistent with that. I've got a watch that measures my heart rate. I check my respirations at certain points, and I look at my finishing point and where I am. So for me, that's just a test to see, okay, am I losing it or not? And that's all been positive. So from that aspect, it's been good. The thing, again, that I want to stress and don't want to dwell on it too much, but I do want to stress it more, was there are some symptoms that are pretty obvious. I did snap my other bicep tendon and it got repaired. So needless to say, I saw the same orthopedic surgeon each time. And I did go back to him about a year later and talk to him about symptoms and what it led to and what I have. Because I said, you're in a big orthopedic group. It's something you might want to share, and I'm willing to share because that was a red flag in 07, another red flag in 2012, and a few in between with the bicep tendons. So again, I think it's important to be aware of this, the symptoms and the disease. I know we go to conferences every 2 years. I talk to patients. We all sit down in a group. And I think they have much more frustrating stories in terms of diagnosis and getting there. And in mine, I think, again, I was lucky. What I did is I wound up with, cardiologists that didn't have all the answers, but wanted to find them. I wound up with one that referred me to an amyloid center or research center that researches the disease. And I wound up with Dr. Maurer. And I think those are things you're not going to come up with the cure. You're not going to come up with all the answers. But if you just know, hey, there's a problem here, let's get it to the right people who we think could diagnose it correctly and accurately. I think from my standpoint, I was very, very fortunate that it did work out and turn out the way it did. So that's my story. I don't really, I could tell you a million more from here, but this kind of, captures the main highlights of it.
I think, the world of medicine is critically dependent on people like John who are willing to take a risk. I mean, we were doing a phase 2 study with this drug called AG10 at that time. As he knows, it was only, 60 days of drug. We didn't know what was going to happen. Not much, information. We had an idea about the dose, but as you can hear, we weren't even set on the dose. There were 2 different dosages. And, the good news about doing it is in some ways you may have won the lottery because you get, not only if it works, you get the drug long term. And he's been taking the drug for 30 months now, at least, maybe 36, 3 years. The drug's got a name now. It's actually not tafamidis, but acoramidis. They even come that far. And we've enrolled 700 people in a phase 3 trial that's fully enrolled. And for those of you who are interested, stay tuned. Later this year, we're going to find out if at least one of the arms of the study related to how far people can walk up and down the hallway is, positive, or if it's effective. But we all, given the experience of John, think it's going to work. And, we all should be very grateful for you for taking a risk and doing that. And actually traveling all across the country. I do remember there was only 49 people enrolled in that phase 2 study in the whole country, and it enrolled in 14 days. So we were like, if you want to do this, you better get your, tukas back to New York quickly because, there are lots of people who have this problem and wanted to enroll. And I'm glad you did. AG10 is an interesting story. Just to tell you, it's a molecule that was discovered at Stanford University. Once people knew that tafamidis was working, chemists can sit there and do what they call high throughput chemistry. And once they know the chemical structure of one drug, they just look through these libraries of thousands of compounds. They found one that looked a lot like tafamidis structurally, but seemed to be a little bit better. One of the reasons it may be better, and this is just maybe more than you wanted to know, but all of this grew out, this whole idea of stabilizing the protein out of a seminal observation by a brilliant woman named Teresa Coelho, who's like a world famous neurologist in Portugal. In Portugal, there's a genetic variant in the protein called V30M, where methionine replaces valine at the 30th position. And you guys are probably in your 20s or 30s, so you'll get this. About 25 or 30 people in Portugal, particularly in Porto, who have this. It's inherited autosomal dominant. They start to get numbness in their hands or their feet at 30. They start to get autonomic dysfunction. So men, you can't get an erection, you can't control your bowels or your bladder, you start pooping on yourself. It's kind of, really terrible. And you basically waste away and you lose weight. And God forbid, by the time you're 40 or 45, you're lose 50 pounds and you pass away. And everyone who gets the gene, everyone thought developed the disease, not the same as some of the other variants in the protein. And Teresa discovered these two grandparents who actually, and this is back in early 2000s, late 1990s, 2000s, who had the gene but didn't have any disease. And she was like, why is that? And she called Jeff Kelly, this guy who invented tafamidis, and he sequenced their protein, and he found out that besides having the V30M switch, they had something called a T119M variant. So at a position 119, they had another switch, and that led to the protein being stable. So one mutation variant would cause the protein to fall apart, but a second was restabilizing, and their protein didn't fall apart. And Jeff published that in Science in 2000. So that was 21 years ago. And he said, wow, if Mother Nature could do this with a change in the genetic code, maybe I could find a drug to do this. And that's how he came up with the idea of originally trying diflunisal, and he showed diflunisal work, but he knew that, like John said, NSAIDs aren't a great thing to take for a long period of time. And so that's why he made drugs that look like diflunisal, and that's how tafamidis came about, and that's then how AG10 came about. So it's a stabilizer, it's not a gene modifier. The other drugs that are being used now are drugs that can go to your liver and tell your liver, shh, don't make any more TTR. They can literally knock down the protein as opposed to stabilizing it. So a different mechanism, and we're hopeful that both will be very effective.
Like a lot of patients that I talked to at the Chicago conference, a lot of them were athletes. And I was a two-sport athlete in college. I moved to Hawaii. I became a waterman. I mean, everything's centered around the ocean. So yeah, that changed. I did marathon races where we raced across the Molokai Channel for 42 miles in an outrigger canoe. And I don't do that anymore. I think the stress of paddling a canoe with 5 other people in the open ocean, I might create an arrhythmia that would I wouldn't come out of. So I got to keep my heart rate, a lot lower than 150 and 160 and 180, which it would probably hit when I do that. So that was a big life change. Jogging, I can jog between 2 light posts, and after that I get a little lightheaded, and I don't push it because I don't want to pass out. So I took jogging off my list, but I will integrate it in my walks when I can. If I had a lot of sleep that night, I'm feeling really good, I go, yeah, why not? So yeah, I modified my lifestyle. Like I was told to keep my heart rate under 120 when I'm working out. I take amiodarone, which kind of keeps it at a low rate. But truthfully speaking, when I do some of my hikes, I'm hitting 130 to 140, and I feel comfortable with it. So I just stay aware. And did I modify my lifestyle? Yeah, profoundly I did. But it didn't mean I didn't change it. I didn't change it completely, because that and meditation is where I keep my sanity.
I have to say, it makes our job, my job, much easier to have someone who's so, compliant and adherent. I mean, as you heard, you can modify life doesn't stop, but, people have to learn, I mean, there's a disease in which the body becomes, because the cardiac output is so low, it can be that the kidneys are not happy. They become very salt avid. So if you eat lots of salty foods, you get really swollen. People don't realize how much salt is in all sorts of foods in the United States and processed. So, the patients who do well, and it's amazing you're not on a diuretic, as if I recall, or if you are, you're on a very, very low dose of nothing, but almost 90% of the patients are. And that's partly because they find it really hard to, adhere to even a reasonably salt-free diet. So, credit
to add to that, I do take a diuretic when I need to.
Yeah.
And that's probably every 2 months. I might go through a 2-day period where I ate too much salt.
Yeah.
And I don't like the feeling. I'm not really bad, but my legs get real swollen. I don't like that feeling or look or anything about it. And like, okay, that was my fault. I'll take the pill for 2 days, maybe 3 at the most, and then I'll just get off it because I go, okay, everything's back to normal. Here I go, and I'll go back to watching my diet. Dr. Maurer mentioned if you take salt out of your diet, the longer you take it out, you're not going to miss it. And then when you eat a slightly salty food, you're hypersensitive to it. It's kind of gross, actually. I noticed in restaurants there's a lot of salt, and obviously it enhances flavor and also hides things. And I'm really aware of that when I go out. And my menu, if I have a fish with the sauce, the sauce will be on the side. If I want to taste it a little bit, I'll do it. I don't deny myself, but I just go, hey, do I need it spread all over the fish? No. So I don't do it.
There was a question I think about, I see here, how does treatment vary? When you say the plaques, the treatments here are based on the biology of the disease. I would say, one strategy is very effective is stabilization. That's what we're doing here, which is taking drugs that prevent the protein from falling apart. There are other drugs that have been approved by the Food and Drug Administration that also work, the silencers that stop the production of the protein. Those are not been completely tested in people with amyloid heart disease. They've been tested in people with amyloid in the nerves, and all of those patients had genetic variants. So, for the patients who are most commonly affected with this condition, like John, who have wild type disease, non-genetic involving the heart, we don't yet know that the silencers are going to be effective, but we're doing studies right now. We expect they will be. The one strategy that everyone in America is always very interested in, I think it's because we're a little bit lazy, I hate to say, and we think that we can let the world fall apart and then just, snap our fingers and resurrect someone, is the idea of anti-amyloid therapies. That is the idea that you can come up with some approach, a monoclonal antibody or something that's going to scrub out the amyloid from that heart. It's going to detergent it out and remove it. And people are working on that, and they've tried it. And those studies so far have all been failed. In fact, one of the more common diseases that is associated with amyloid you'll probably encounter in med school is Alzheimer's disease. This is not related to that. It's a totally different protein. Everyone with this condition does not have, in my experience at all, any cognitive deficits. They're all very lovely, bright, and so forth. But they've learned that, trying to treat someone with advanced Alzheimer's disease with antibodies to get it out of the brain doesn't work. Maybe there's a signal if you start a little bit earlier. But so personally, I advocate what we need to do, like talks like this, is get you guys to be aware of this diagnosis so that we don't wait for someone to have, an advanced condition and then start to apply these therapies, because they work much, much better when you're early in the course of the illness as opposed to late in the course of the illness. And that's probably the most important message, besides think about it is, I can tell you, if you can diagnose someone really early, or the patient can figure out how to get themselves diagnosed early, which is what you did, then they're going to do much better than someone who's diagnosed with an advanced condition. The other things I would just note is, you'd think rare diseases are really uncommon, but I have to say, I'm not sure this meets this condition actually is going to be that rare. The definition of a rare disease in the United States, if you don't know, by the Food and Drug Administration, is less than 200,000 people who are affected. You can do the math. You can divide 200,000 by 330 million. So that's like, 50 or 60 people per, 100,000 or something like that. I mean, there's some data to suggest that in hospitalized patients, we're already at that metric. Interestingly, these drugs get approved on the basis of a rare disease designation, which means the bar for the Food and Drug Administration is a little bit lower. They get worried about approving drugs, that affect like 70 million people, and they don't have enough information. But when they think there's not as many people, tafamidis, for example, the drug that we talked about that is approved, that's a stabilizer, it was approved on the basis of one study in 441 people, not a very big study. But there's a lot of developments in rare diseases, in all of medicine. And it turns out there's, thousands and thousands of rare diseases that affect quite a bit of people. So something that I think interesting to focus on. I mean, back to what I think John said. I mean, the most probably important people we need to educate right now are twofold. I'd say orthopedists, because they see a lot of people early on who probably have this. And it's not even just educating them. It's I wish they would just send the tissue that they get from the surgeries. They often, I don't know if you know, the guys know this, but they do carpal tunnel surgeries in their office and they chuck that stuff in the garbage. They don't even look at it, right? I mean, we can't even convince them that they should stain it. And you know, the staining of the tissue is like $5. I mean, like it's tests that get done, you know. Now we also need pathologists who are experienced in all of this. Maybe someone in your medical school will figure out a better way than, you know, Congo red staining. By the way, Congo red is like a stain that was invented by Virchow, who was a pathologist in 1874, and amyloid means starch-like. So, I mean, we're using techniques that are like, you know, 150 or 250 years old. It's kind of cuckoo, but they still work pretty well. So I think those of you who are going to go into orthopedics, you know, please think about this and remember that, you know, their role is not to just fix the ligament, but think of why it's, you know, the bone or whatever's happening. You know, to John's point, we did a study in which we kind of observed that many of the patients with this condition had disproportionate hip and knee replacements. That's just, we were seeing people. Though we were a little perplexed because many of them, like John, were pretty big athletes. So it was kind of like, are they getting the hip and knee replacement because they were such big athletes they wore out their joint or something? So, you know, we did an analysis and we found out that the, what we call odds ratio, that is the chance of having a hip or knee replacement in people with TTR amyloid, which is this type you have, versus a different form of amyloid called AL, was 3 to 5-fold higher. And it was much higher than what we call age and gender match control. So, you know, you would think that if you're taking a whole hip out and the, you know, acetabulum in the head of the femur, and you're like sending it off to the pathology lab, someone could just like take a little snippet of that and stain and see if there's amyloid around there, but they don't seem to do that. So that's something we're trying to do kind of in the country, educate people. To be honest, doesn't go that well. I don't mean to be this way, but many of you may go into orthopedics, so don't take this the wrong way, but they're kind of bonehead. They really don't listen to us very often. And we bang our heads against the wall asking them to just, you know, no big deal, just send it off to the pathology department, but that's not happening. There's a great paper, if you have nothing else to ever read, about diagnosis and how to think about making a diagnosis. It's in the New England Journal. It's by a guy named David Eddy, E-D-D-Y, if you can find it. He was like a famous educator at Duke University. It's one of my favorite papers. Do you guys read the clinical pathological conferences in the New England Journal of Medicine? You know, they present a case of a patient and someone discusses what they would do to work them up. Yes, no, anybody? We used to be required in med school, you read that case every week because that would teach you how an expert would think about it. So he did this great thing where he took 50 of the cases and he analyzed them. He discovered, by the way, that people at Harvard more often got the case right than everywhere else, but he didn't think that was because they were that smarter. He just thought that in the hallways of Harvard, the really interesting cases were being discussed, and so everyone had kind of like an inkling of what was going on. But imagine you're like the discussant for one of those 50 cases, and in front of the world of medicine, you actually guess at the diagnosis and you got it wrong. And that happens, right? You're like, I think the patient has amyloid or hypertrophy, and you're wrong in front of, like, written, because that's how it works. You write down your answers. He analyzed it and he found out that the people who most often got it wrong, he wrote this 6-step process that we all go to. We listen to the patient, we're hearing their story, and we're generating kind of a focal point that we want to focus on in hearing their story. It could be shortness of breath. It could be palpitation, something that you think you want to generate your differential off of. And then you go through a long differential. And then you're kind of, while you're listening to the story, you're hypothesis testing. You're like, well, they say this symptom, carpal tunnel, so I'll move amyloid up and move hypertrophic cardiomyopathy down. Oh, he could have hypertension. But when I examine him, his blood pressure is low. So how could, he said it was 90/60 when he passed out. So how could high blood pressure cause a thick-walled heart if his blood pressure is low? So that's what you're doing all the time. But he basically, back to the point I was making before, he said the people who got it wrong were the people who didn't come up with the long enough lists. So when I say to medical students, when they're presenting a case in front of everyone in our place and the residents, I stop everyone after the HPI and I go around the room and I say to everyone, name something that could be causing this patient's symptoms. And we come up with a long list, we write it all down on, and then I go back to the med student who's presenting the case and I say, is what this patient has on that list?
And if the answer is no, then we all screwed up, because there's no way we're going to arrive at the diagnosis if we didn't think about it to begin with. So that's a good process to go through. And presenting is a little bit of performance art. You don't want to be boring about it. You want to be like enthusiastic and emphatic. And to be honest, if you make a presentation, I always say to the med students, and no one comes up with the diagnosis, then you kind of didn't really give a good presentation either. You don't want to like stump the chump. You want to lead people toward where you think things are going in some regard. But, you know, making an accurate diagnosis can be hard, but that's philosophy. But David Eddy, New England Journal, I don't remember how long ago. My pleasure. I really want to thank you both for setting it up. It's really great. And I think, you know, we got to do more of this.